Welcome, everyone. This is DDU teaching session number 1 for 2025. Feel free to put your cameras on if you want. This is a session that you won't really get asked many questions about. And it's a pretty easy one because it's not about echo. For those that don't know me, I've met a few people, I think. Awesome. Someone's got a camera on. Thank you. It's so much nicer to talk to at least one face. Hey, do thanks, Rob. So this is great, I'm going to win this, a session on lung ultrasound. So Sam asked me to present for the first one to be on lung ultrasound, which I'll do. It's pretty straightforward. It covers a bit of the fundamentals of lung ultrasound, really. At this time of year, we get a few new people joining the lecture series or program, whatever you want to call it. So this stuff is not high-end sort of research level diaphragm ultrasound and stuff like that. This is just the fundamentals of lung ultrasound. And it is got a few videos and stuff like that in it. As usual, any questions along the way, please ask. And that's all we do. I will just share my screen. All right, so I'll call this part 1. Whether I get a part 2, we'll wait and see. I think that the few things to remember about lung ultrasound. So this is a small portion of the DDU. As someone that sat the Viva twice, I'd say you want to absolutely know the fundamentals of this, not because you should expect to get asked complex questions about it, but because the overlap of lung ultrasound with the rest of really what the DDU program is, which is a lot of critical care echo, having people on a ventilator and being able to get them off, the evidence for using lung ultrasound in assessment or to complement your assessment of left atrial pressure and weaning failure and all that sort of stuff, not to mention some simple point of care things, pneumothorax, pleural effusions, pneumonias, that sort of stuff. So that's the principles of lung ultrasound being incorporated in this program. Now, lung ultrasound predominantly uses artifacts, not direct vision. There are some exceptions to that, things like a pleural effusion and pneumonia are examples there. But otherwise, the fundamental principles of lung ultrasound are that ultrasound and air don't mix, as we know. So we're using artifacts to make our decisions as to what we're seeing. For the majority of pathologies, I would say that lung ultrasound is better than a chest X-ray in virtually every way. And the amount of evidence for that is growing. So the amount of evidence for that in the pediatric population, the amount of evidence for that in the adult population, in the critically ill, in the outpatient setting, in resource-rich and in resource-poor countries. There is growing evidence that for things such as pneumonia, pleural effusion, pneumothorax, a point-of-care lung ultrasound has at least as good, if not better, sensitivity and specificity. So it is better than a chest X-ray. I'm having some lively discussion with one of the local universities about how lung ultrasound should really be incorporated or ultrasound in general, but in my context, lung ultrasound should be incorporated in some of the clinical case-based learning sessions that they do, because I think medical students nowadays need to know how to do this, or need to learn how to do this because it will be expected. And ultimately, lung ultrasound is far, far easier than echo, so that's important to know too. So I had to have a couple of slides on physics. So sound waves, a sound wave is just a pressure wave that's going through a medium. In our case, it's tissue. Our amplitude is a measure of the peak pressure of that sound wave. So the more that comes back to you, the stronger your return signal is. It means you've had more, like a higher amplitude reflected. The ultrasound speed through a tissue varies depending on what the density of that tissue is. Now, the machines themselves make assumptions as to what that density or what that speed is. It kind of averages out the majority of the soft tissues in the body, but air is fairly different to that, which is important. Acoustic impedance, that's how much resistance that those molecules have. And the impedance is important because it's that tissue interface between two different types of tissue. It's that interface that gives you different levels of impedance, and you get more ultrasound coming back if it's greater, and therefore less ultrasound energy goes through. So if you have a really bright reflector, lots of stuff comes back to you, very little energy goes through underneath, and that's important when we think about ultrasound and lungs. So one of the things that my trainees ask is, or I point out to my trainees really, is that you have bone, which is profoundly dense in terms of what we have in our human body. We have lung, which is predominantly air, but on ultrasound they look really similar. So you have, I don't think I have a cursor. You know, on the top there, we've got some cortical bone. That's actually a fracture, according to the website I stole it from. We have that really bright white line, which is that cortical bone. And then we have a really bright white pleural line. And if you keep ultrasound machine settings relatively similar, they can look really similar despite them being really different tissues. And the reason that happens is because it's that difference in interface that gives you such a bright reflection. So when you go from soft tissue to bone, you know, a lot of difference there. And so you get a lot of ultrasound coming back. And when you go from soft tissue to air to the lung, again, it's a really big difference in that acoustic impedance. So that, again, is why you get that bright reflection. It's not physics. For those that are going to sit module 1, the DDU module 1 exams, you know, you expect some questions on the fundamentals of physics and some of these formulas and stuff that they use. In terms of being pragmatic and practical about using lung ultrasound now, so it's really important to do the same thing every time. You know, a curvilinear probe is great, and most of the point of care ultrasound machines, be it a Sonosite, be it a GE, Venue, will all have those curvilinear probes, you know, sort of a 5 to 12 or a 5 to 12, I think they are. You can absolutely use a high frequency vascular access style probe. They're great, especially if you want to look at something that's just pleural or subpleural. So you really want to see what that pleural line is doing. Absolutely getting the vascular access probe to try and identify pneumothorax. A far better way to go if you can't quite see compared to trying to use a phased array or a curvilinear probe. When you're looking at the lung, make sure that you've turned all the harmonics off. You want to just use a fundamental frequency. So if you're looking at a pleural effusion, you know, most machines will be set up so that you've got abdominal and lung and maybe even pleural default settings. So if you really want to look at the lung itself, so you want to look for B lines and you want to look at the pleura, make sure that you have it set so that it's on lung, because that will, generally speaking, turn the harmonics off. If you're doing an echo and you want to take some extra pictures of the, you know, lateral aspects of the chest, for example, because you think maybe they're wet, then just go to the settings and make sure you turn harmonics off. You'll be able to see the B lines, for example, much more clearly that way. You can have false positives and false negatives. From a convention point of view, if you're doing a dedicated thorax or lung ultrasound, and we, at least in Australia, we start with the diaphragm on the right-hand side of the sector. So the best way to start is to get the probe, hold it like this, and whack it on the chest wall, start at sort of the costophrenic recess, and look to have some organ. So be that liver or spleen, if you're on the right or the left, dial in your gain a bit based on that, and have your diaphragm curving in that way. And then you can pan up, have the ultrasound probe in a craniocaudal or plane, and go up from there or go around from there. Trying to start with the ultrasound, especially if you haven't done much lung ultrasound before, trying to start in a plane that is sort of more of an AP plane can be quite hard to get your head around just the 3D anatomy, because you can just slip up and down just a little bit, and then all of a sudden you're catching some diaphragm as the person exhales in the far field, things like that. So if you go craniocaudal and then pan through and around and move from there, generally it's much easier to get your head around to start with. There's a bunch of protocols. The one that most people know about is the Blue protocol, which I've got on the next slide, by a guy called Lichtenstein. It's through all the literature. It has been for years now. I mean, it's beautiful. And it's not that many points to actually ultrasound. They have the nice flow diagrams with it as well. And if you want to go down the road of learning that, it becomes a sort of pattern recognition thing, and to think about, okay, I've seen, you know, A lines or B lines or whatever. I think that being able to, or being comfortable at the very least, to scan more of the lung fields themselves, just taking the probe and, you know, effectively lawnmowering it over the hemithorax is a really good way to go, because you get to see more and you can miss subtle things. Now, at the end of the day, if you've got a really unwell patient, the things that you're looking for won't be subtle, they'll be bloody obvious, right? However, it can be quite useful, loculated, you know, collections, things like that. Regardless of which way you go, whether you learn protocols, whether you just learn some zones, you know, there's a 7-zone one, as I've got here, there's a 4-zone one, 8-zone one, you can make it up, right? And as long as you label it, that's the key part. Label where your images are being taken just on the ultrasound itself. And that way you can always track back. It's also really useful to label it, because there's some good evidence about, you know, diuresis, and the amount of B lines, for example, that someone has is an effective way to gauge how your diuretic effect is going. So this is the blue protocol. They talk about measuring or taking some pictures at 3 different points. There's an upper and lower anterior point. And so you put your hands over the person's chest with your upper hand. So on the picture on the left-hand side of the screen, put your little finger under the clavicle with your 2 hands together like this. And the idea is you measure under the middle of each point of your hand, put the probe on there and there. And then there's the P-lapse point, which they've got plotted out on the right-hand side. You take a picture at each one. And you can run it through profiles like this. I'm not going to labor this. It's in a lot of books, journal articles. You can track it down if you want to. It works. But you end up with this sort of flow chart. Again, you incorporate your clinical acumen into this, of course, but that's how you can go. I'm going to take half a minute just to talk about some of the anatomy and some of the components of the lung. So if you think about someone's chest wall and you've got your extrathoracic tissue, so that, obviously skin, muscle, fat, that sort of thing. And then underneath that, you've got the lung. So lung are big grey blocks, right? Grey box. You've got your ribs and your tissue sitting in the middle of those two. And so what you end up getting is you end up getting this, in your pleural line, you end up getting this bony shadow. And the bony shadow obscures those two sides of the lung, right? Because you just can't see it through it with your probe. You can still see the pleura under the tissue, but you'll be able to see that under the ribs either. And this is the anchor point, really, for what they call like the bat wing sign. And you see that written in textbooks, what a normal lung will look like if you put the probe on, where the ribs themselves are the wings of the bat, and that little divot in the middle where you can see a bit more soft tissue is where you get your intercostal musculature and then your pleura, and then that's where you'll see your B lines or your pathology is through that space. This is the schematic representation of it. Again, people talk about being a bat wing, I think. It's pretty commonly referred to in books. For reasons that I have no idea about, we talk about A lines and B lines predominantly. So an A line is a reverberation artifact. We see this all the time when doing echoes, right? But these reverberation artifacts have a few really key points that you have to be able to recognize, because it's very easy to mistake these for pathology. So because it's a reverberation artifact, it's thought to arise from where your probe is on the skin and that where that probe is touching to where your pleura is, pleura being a really bright reflector. The ultrasound comes down, hits that really bright reflector. Some of it comes up, doesn't get, some will come up, some will come back down again. And so you end up getting these equidistant lines that come down the sector from top to bottom. The space between all of them will be the same. And as you get further down the sector, the brightness of them will get less and less and less. As you can see on the picture here, they sort of fade out. In some people, you'll see 4 or 5 of them, like in this picture. In other people, you'll only see 2 or 3 of them before they completely fade out. They're really important because they denote that there you've got normal lung. It means that there's not an effusion, there's not a pneumothorax, there's not consolidation that you can see. So they're a really important marker to be able to recognize. Z lines. So Z lines are vertical lines. They sort of run from top to bottom of the sector, and they'll start at the pleural line, and they fade as they go down. And they don't move when the lung moves. They don't move with lung sliding. These are a really common thing to mistake for B lines, right? So I put A lines and Z lines first because they're both normal features. You should see them. A lines being those horizontal lines that fade, and Z lines being vertical lines that effectively fade as well. They start at the top, they come down, but as they go down the sector, they disappear towards the end, as you can see in the picture here. We don't know why they're there, they just are. We don't think they mean anything, but you'll notice them in some patients. And I contrast those with B lines. So B lines are one of the key features that you'll see when you do a chest ultrasound or a lung ultrasound. So B lines are these lines that start there, so they run vertical. They start at the pleura, and as they get down the sector, they will not fade. They are like someone is standing there with a spotlight that keeps going and going and going, starting at the pleura and going out. So as you get further down the sector, they persist, and they are broader at the base of the sector than they are at the top. It just expands, which you expect with the ultrasound anyway, because of the physics of it. So they will obliterate anything that is underneath them. So a B line will come down over the top of the A line and make the A line disappear underneath it. So a couple of features that differentiate that from a Z line. You know, a Z line won't obliterate an A line, it won't go all the way down, whereas a B line will. We are allowed to have a couple of B lines. Every person's allowed to have a couple of them. So at the apices of the lung, you might have one or two. At the base of the lung, you might have two or three. That's all considered normal. Some resources say three is normal. Some say three or more is abnormal. It just depends on where you read. They're really thin. Ideally, a B line is really thin, and as they coalesce, they get bigger and bigger and bigger. They can take up that entire interspace, just one giant B line. That in itself is pathological. They should start narrow and be narrow the whole way. But if you've got a whole group of them merging, then they'll start to coalesce, become a big thing, and you won't see anything underneath it. They're a marker of an interstitial process, which I'll mention again a bit later. This is not this is just an image. It's not a sliding dynamic GIF. So the pleura is that bright white line. When you can see the bright white line and you can see things sort of tracking underneath it, like an A line there, it tells you that you have a intact pleural interface. So the pleura is up against the visceral pleura is up against the chest wall, which means you don't have a pneumothorax. You'll see it move. They talk about lung sliding. They talk about I think stratosphere sign or the sandy beach sign or something in books if you put an M mode cursor through it. But you'll see this move and it tells you that the person's ventilated and the lungs up. I think that identifying a pneumothorax is really hard. It's one of the hardest things to do unless it's blunt or obvious. One of the key features of a pneumothorax is what they call lung point, which is the leading edge of the lung. So if you look at the image on the right there, where that lung is just starting to take off, so come away from that chest wall, that's the point you want to look for. It means that if someone's got a pneumothorax, depending on how they're positioned, will dictate where you can see what. So if I've just done a tap in clinic, put a needle in, take down half a litre or a litre of fluid, take the needle out, and a bit concerned I may have touched the lung, then I have the patient sit up, look up here. If you've got the patient prone or supine on a ventilator and you're worried there's pneumothorax, and you've got to put the probe where the air is going to go, right? What you want to do is look for where that point is. You want to look for where the lung sliding disappears. And that takes time, and that takes moving the probe with a whole lot of gel over someone's chest gently up and down, looking for it, depending on, on how they're positioned. It's 100% specific for a pneumothorax if you can see a lung point. You just can't always see it. So this is just a still image. I've got a clip on the next slide. But you end up going from this point of normal lung to abnormal lung. And if you look at this still image that I've clearly stolen from Rebel Emergency Medicine, it's very hard to pick like what the difference is there, because you can see a pleural line intact, you can see a bit of crap underneath, you can see the ribs. On the right, they put an M mode cursor through, and you can see at the bottom you've got the like the bottom part of the sector, you've got that grainy sand sign sort of thing they call it, and then as you go over to the right, as you can see, it's just become all straight lines, but all the straight lines the pneumothorax. But I think a better way to show it is this. So this is what it looks like dynamically. So coming in from the right side of the sector, you can see a pleural line that's moving as the person breathes. You can see all the B lines coming off and coming down. There's a bit of water or interstitial process in that lung, but then it just stops. It's just like a straight up and down stop. And that's where that lung is no longer contacting the inside the chest wall. And so everything to the left of where that stops, everything up that way, where you can see a bit of tissue moving, or what looks like a bit of tissue moving in and out, that's nothing. So what is under that pleura, you can't see. You have no idea. It's just space. You don't know whether the pneumothorax is that big, whether it's that big, you have no idea. But you do know that the lung is no longer touching the pleural, at the parietal pleural edge there. So then in terms of procedures, or if you want to try and get some air out of it, or whatever you're going to do, you go, all right, you have to be in this image to the left of that. But again, you don't know how far down you can go. Make sense? Yeah. Like I said before, and picking pneumothorax is really hard unless you've got a sign like this where it's just lung, 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 and then stops. And that's lung point. That's the easiest, sorry, not the easiest, that's the most specific thing to look for. And if you find it, happy days. If you can't find it, but you're still suspicious of pneumothorax, much harder. A quick word about intercostal vessels. So you can absolutely see these. You just have to put the Doppler on and turn your gain like all the way down. Now, as I'm sure you all know, within that 5 to 10 centimeters of the spine, if you go out laterally, then the intercostal vessels don't sit or don't always sit up under that sort of neurovascular bundle under the rib. They can be anywhere in that space. So if you're doing a really posterior approach pleural procedure, be mindful that you can easily hit a vessel there. It's not until you get around further that they tuck in under more. As people age, these vessels have been reported to sort of no longer sit up in there, presumably because of like connective tissue loss of integrity, and they can sort of drift out again. But it's definitely worthwhile putting just a color box on, especially if you've got a machine that can do power color, because that will pick it up a bit more easily, so a bit more can generate the color easier, and you can avoid them. So it's very easy to, if you're praying an intercostal artery especially, like that thing can just bleed and bleed and bleed, and you never know because it's going to bleed to where there's no resistance, which is into the chest wall, or sorry, into the chest, like the pleural cavity. It's always worthwhile having a look. And then finally, from an anatomical point of view, remember that the pleura is everywhere. So the pleura is obviously over the lung, the visceral pleura itself. It's obviously over the inside of the ribs, the parietal pleura, but it coats back up over the diaphragm, coats back up over the mediastinal structures. So in this image, for example, we've got a big pleural effusion there. We've also got a little nubbin of something sitting on that diaphragmatic pleural surface. So pleura is everywhere. If you're suspicious of something that's a bit funny or a lump or a bump and you see it and sitting on a pleural tissue like this, it's cancer until proven otherwise. Just again, if you see a large pleural effusion and the pleura is irregular, unless the person's had like a talc pleurodesis or something similar, you see stuff like this is cancer. This is a mesothelioma. All right, I'm going to talk a little bit about some of the pathology now. I've got a few more slides, so a few more images, videos. So interstitial pattern in general is something in the interstitial space, right? I mean, it's obvious. That can be fluid, and 99 times out of 100 in the intensive care unit with a critically unwell patient, it is fluid. But occasionally it can be fibrosis. And in my world of respiratory medicine, we see it being more fibrosis than the former. You can't tell the difference very easily. There are some reported signs on ultrasound you can use to say whether someone's in cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. And while some large data sets sort of indicate one or the other, by no means have I seen any data that says it's clearly diagnostic. One of these features are clearly proof that is or not. So there are some things you can manipulate around to help you, apart from the history, is gravity is the big one. So if the patient has basal or posterior, depending on their position, predominant interstitial markings, then it's far more likely to be fluid. And if you've got patients that you're proning because they're in ARDS or similar, and those lines move, then all the more proof it's fluid. If the lines are static, then you can think it's either sort of higher protein interstitial fluid or it's fibrotic change scarring. This is an example of where there are extra features that can help you. So left-hand image, you see the multiple B lines coming down from that pleural surface. They're coming down, getting wider as they go, and they're destroying anything that's underneath them, and they're going to the bottom of the sector, right? B lines. On the right-hand side, same thing, but you can see that pleural surface is ever so slightly irregular, like someone's just taking little nibbles out of it from the outside world. That's subpleural consolidation, those little chunky bits that are missing. So that is an infective process or an inflammatory process. So you can look at the one on the left and you can say, oh yeah, they're probably wet. Look at the one on the right and say, oh yeah, it's probably infection, or at least partly infection, partly not infection. Things like that. Again, not definite, and obviously patients can have as many diseases as they please. So this is just one example. Hopefully it's projecting all right. I just stole them down before, where these were some images from a patient that their images are now being submitted for a case. So it's all been labeled pretty well. It's got left, infero-anterior and antero-superior. I guess anatomically speaking, I should have the bottom on the top. Sorry about that. But you can see at the very top of the sector, you can see the pleura is moving back and forth as the patient's got a respirator of 30 or 40. They're puffing away. You can see the B lines flicking down. They're destroying what's beneath them. They're going down, not quite to the bottom of the septum here, but that's because the depth of it and the TGC has been pushed really far back to at the base. But you can see they just keep going down, down, down. And then the images on the right show some beautiful chunky consolidation. You can see some lung that is just barely, it's not ventilating, right? It's moving, but not getting bigger and smaller. In the bottom, they'll put color Doppler on, showing some color going through those vessels there. So it's still got blood flowing through it, but it's just not being ventilated. And you can see off the top image on the right-hand side, you can see what looks like B lines coming off that chunk of lung, but they're not coming from the pleural surface. They're coming from air within that bit of lung. So there's still a bit of air in there. You just can't get the air out because you can't ventilate the patient, in that part of the lung anyway. There's some pleural effusion. So you patch it together because patients will have as many lung findings on ultrasound as the pathology dictates. And it's very rare that you see something pure. It's very rare you see just consolidation or just B lines or something like that. You'll often see a mix of each. This is an example of some of that subpleural consolidation I mentioned before. So you can see it can be really subtle. The depth of these fields here is like 5 centimeters, and certainly the one on the right, and I think the one on the left as well, is using a linear probe. You can tell by the top of the sector. Really zoomed in, little chunks nibbled out of it, right? And so that is what this subpleural consolidation will look like. These are the first phases of a pneumonia in many patients. And these are the ones that can have a completely normal chest x-ray, but still be febrile, still have pleuritic pain, still feel short of breath, but not necessarily be hypoxic, with white cell count of 15, CRP of 100. I absolutely see this in the emergency department. I get a call from the ED saying that someone's got a normal chest x-ray, but they're coughing and they feel crappy and high inflammatory markers. And you put the probe on and you see this, and it's like, beautiful, diagnosis made, you don't have to go hunting anywhere else. This is subpleural consolidation. You take consolidation to a bigger stage and it looks like this. So on the right-hand side, you can just see a much bigger chunk of that sort of eaten out appearance with a lot of sort of darker patches at the top. And then underneath it, you can see some B lines coming off where the pleura's, or where there's air sitting there. And then on the left-hand side, they've got on abdominal settings. That's why it sort of looks like sort of grayscale. And you can see scattered all, ridging around the entire lung like that is that consolidation, that dense tissue that does not look like air. It doesn't look like lung. It looks like solid tissue, right? So I talk about hepatization. This is another example of some pneumonia and some lung collapse. It's moving relatively quickly. I'll see if I can slow it down. So if we go, like stop here in the middle, we've got our rib shadows coming down the center here with some collapsed lung down in the middle of this, and then fluid all around it and some septations that you see sort of bridging out there. A nice septation coming through here. I didn't do this because if I did it would be flipped going the other way. But you can just see how that collapsed down lung floats in the middle. It looks like soft tissue, does not look like lung. And you got this black stuff around it, which is going to be pretty manky pus-like fluid. And here's another far prettier example, I think. You've got some collapsed lung coming in through here, and infected looking lung coming down through here. Big effusion at the top here, completely raggedy, heavily septated lung all through here, some ascites through here, with muck in that as well. This is the sort of stuff you'll see. You go hunting for it, you find it. You can then put color over this, and you can see like so this is air bronchograms in through the center here, where there's that really bright white dot and some lines coming off it. We know it's air because it's giving that artifact, right? So that's an air bronchogram, and if you put color over it and you saw color flicking in there, that'd be your vessels. This is what's referred to as the plankton sign, if you've come across that in textbooks. So those nice sort of bubbles floating around there, that's blood. All right, so this is a pneumothorax. Whether this is from trauma or not, I don't know. But you'll see these swirls just sort of float through it, and over time that will settle, but as the patient moves, it will move again, right? So you put a probe on someone's chest, you see this in terms of an effusion, and you can really confidently say that it's either there's a high percentage of blood in there. It may not all be blood, of course, but there's a lot of blood in there, hence that swirl. So that's the plankton sign. Stuff like this is absolute fodder for the DDU Viber. They just show like a single cine like this for some of the stations, and we'll say, all right, what is this? And it's like a spot diagnosis station. And this is just some more examples of septations. So historically, the Lights criteria would break down a pleural effusion into transdates and exudates. And that's a nice historical way to define them, but practically it doesn't mean a whole lot, because you get a bit of blood in there and it will go from being transated to exudative, and that could be procedural blood because you're praying something you've gone in. If you've got if patients on diuretics, it will go from being transudated to exudate, despite the fact that it's a consequence to organ failure. But if you see septations, you've got to start thinking it's going to be pretty bad. And certainly a few septations like the picture on the left, no worries. But a lot of septations like what's on the right can actually get really hard to pick. Is this heavily loculated pleural fluid, or is this actually like a lung with abscesses in it? It can be really hard to tell if it's bad enough. Stuff on the left is something that I'd put a drain in, and then if I didn't get it all out, I'd do lytic enzymes into it. Stuff on the right is, unless the patient's too unwell for theatre or too like frail for theatre, they're the sorts of patients that I'd be sending off for a VATS, decortication and pleurodesis, not pleurodesis cancer. This is, scroll back towards your chest. You can see it going that way, back towards your midline. What I was doing. Get towards your arm, it goes down that way. And if I go up, just on the edge of your clavicle is there, going down. So this is the young woman that presented years ago now when I was working. If I scroll back towards you in a different state with infective symptoms and a mass or what looked like infection on her chest x-ray, but when you come and have a look at it with ultrasound, you see this well circumscribed lesion that had vessels all going through it. We did a percutaneous biopsy with a TrueCut needle, and it was breast cancer. When in mid-20s, right? Looked infected, history of infection, didn't get much better after antibiotics. You find this, because on a chest x-ray, I said, it just looks like a big round consolidation, right? But it's not. So you can find some funny things sometimes. In terms of effusions, as I say, we can think of them as extra tranche if you want to, but it doesn't really change a whole lot practically. That is, you can get all other stuff in your fluid, in your pleural cavity as well. Chyle is one you can see, hydrothorax and like hepatic hydrothorax, and you can just get urine there as well. It's sort of urothorax. What I didn't go through before was, gauging its size, or if it's small or medium or large. And you see a CT report come out saying a small or a large pleural effusion. I don't know by what parameters radiologists define things as being small, medium, or large, but certainly on a CT, things can look a lot bigger than what they are under ultrasound. There are some people out there that talk about, it's 5 centimeters or 10 centimeters deep, as deepest volume when you're measuring a pleural effusion. That's not, you then times that by 20 and you get a volume, right? That's not being proven. There's no data about that. It's just like some old wives' tale. So if it's 5 centimeters deep and you go, 5 times 20 is 100, it's not going to be 100 mils or a liter or whatever. It's just as big as it is. The final thing I've got in the bottom line there is posterior acoustic enhancement. A really nice extra sign for your pleural effusions. Everything looks brighter underneath. And this is just a case from an hour and a half ago because I'm on call today. So this is a guy who's actually 67 years old, I've since found out. So he's a C4-5 quadriplegic from a working accident from 2005, I think it was. And he's been unwell for a week with a wet cough. He's got a suprapubic catheter in. That output's been fine, not bringing anything up, just sounds a bit congested. He's got no atrial fibrillation, heart rate of 130 in the emergency department just now. Systolic blood pressure is about 80 to 85. and his stats when he came through the door were in the 70s on room air, and got up to about 90 on 40 liters, 40% of high flow. He has no underlying lung disease, and surprisingly, really, he is not on nocturnal ventilatory support, because with a lesion that's that high in his CS1, you have to think about, does he have, phrenic nerve involvement and a degree of diaphragmatic dysfunction, which will lead him to hyperventilate at night. Maybe he's just never had a sleep study. I don't know. It was a bit too unwell to ask him, and I saw him before. But he's got no respiratory support. And so this is his chest X-ray, and it looks pretty atrocious. What I couldn't pick from that X-ray was what's actually happening down that left base. He's got a systolic blood pressure in the 80s. He's got a lot of swing on his art line. Is that a large, funny pericardial effusion, or is it a pleural effusion? And then in his right lung, obviously pretty bad. So after we've got an instrument of consolidation. Right, so this is right upper, this is right near, it's coming in, and then through here, this is right level zone, all these B lines coming through. Here again. Coming through here, this is just the start of his left base. I didn't take a whole lot of pictures of his left base because there was someone else doing an echo. But you've got consolidated lungs sitting in here with the effusion around it. His echo ended up being reasonable for him, no effusion. But he's got good going consolidation up in the right, in the middle as well. Heaps of B lines, so there's water everywhere. And he's got an effusion on the left. So again, one patient, multiple pathologies on the ultrasound. It's really nice to be able to go through and go, okay, this is this, this is this, this is this. He's got an interstitial, we've got to drain the effusion, got to dry him out a little bit, maybe, given what his lungs look like. Got to give him appropriate antibiotics. Got to be worried about developing an empathy or something on the right side, given that you've got a lot of consolidation on the right. And that's where I was going to stop. So things I didn't cover, and the things that are sort of can be thought about in terms of lung or chest ultrasound, is dynamic assessment of weaning-induced pulmonary edema. For anyone that's doing the EDEC program, or we haven't seen any of the EDEC lectures of the European Diploma of Echo, they have some resources and a lot of discussion around that often. Looking at someone's left atrial pressure, and then as you extubate them, or if you're going to extubate them, seeing what their B lines are like and engaging that. And then also diaphragmatic function. So you can measure diaphragm movement. You can measure how far it comes down when a person breathes. And you can also use Doppler to measure some of the vasculature of it. But seeing how strong someone's diaphragm is, but how far it moves, and seeing how thick it is, and if it's getting thinner, sort of research to just beyond research now, like slowly coming into people's clinical practice. Especially in assessing critically ill patients, or people that are, have just been extubated and they're not doing very well, and they're trying to get them out of the unit, or trying to optimize their lung function and their diaphragm function before you extubate them. Looking at what you can do with the diaphragm and seeing optimize that before you do further activity is sort of coming into play now as well. And that's it. Shorter one for the first session. Any questions?
Does stuff like the Doppler of the diaphragm come up on the DDU exam?
No, don't expect it. So Sam does he's had a bit of a play with ultrasound of the diaphragm, but he doesn't do it very often. It's harder than certainly I find it challenging to actually get the diaphragm in good position, right? Because to get the patient position how you want them, and to be able to see the nice thick diaphragm, the textbooks and the guidelines for it make it look easy. Like, you just do this and put the probe here and you can see blah, 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 blah. But to actually see that, I think even in a well patient or in a sick patient, positioning them so you can actually see the diaphragm well, I find it really challenging. It's nice when you've got a huge effusion and the diaphragm's everted, so it's gone the wrong way. You can see all that sort of stuff. It looks cool. But in terms of gauging it for like examination and stuff, no, I wouldn't expect that at all. And if it was there, it'd be one of the things that is to differentiate the good candidates from whoever the person is that's going to get the award, right, for topping it out. Yeah. And if not, then we call it. So
Ben, I've got a question.
Yeah.
So in one of the slides that it shows someone with the normal X-ray, and then on the ultrasound you pick up these early signs of pneumonic processes. How specific is that? If you are able to elicit the sign on the ultrasound, will you be like comfortable not to like,
Absolutely.
go down the route of, okay, let's do CTPA, rule out PE and other things? Or
yeah, so if I saw a bit of consolidation, so normal chest X-ray and some consolidation or even B lines on ultrasound, I would be happy to not do any further tests. The exceptions to that are if they had a really high Wells score, for example, or they were, if they just had a lot of features screaming PE, then I'd do a CTPA. Sam. Then I'd do a CTPA, right? So those sorts of diagnoses have to still think about, because whilst there are some features on ultrasound of a PE, you can see a wedge infarct on ultrasound, but it's got to, a wedge infarct will appear late, it won't appear early in terms of the clot. A wedge infarct will look a lot like consolidation. It's got to be peripheral, and it will change dynamically over time. So picking a wedge infarct is hard. I certainly never go looking for that, even in patients that don't have PEs. So a PE is probably the one diagnosis where I would scan if I didn't have any other lung, if I had other concerns. Whereas if they looked and smelled a bit like infection and they had clinical features of it, and the normal X-ray, and I saw those sorts of things, I saw B lines, I saw subpleural consolidation, I wouldn't do anything further, just give antibiotics. And when they're well, when I have patients that are like, well from the end of the bed, so to speak, because these people come into ED all the time, and if I find stuff like this, then I'll give them antibiotics, send them home, and happily call it.
All right, great, thank you.
Didn't see you there, Umi. I would have asked you a bunch of questions had I not. Where are people up to in the DDU process? You've got people seeing the vivas and writtens and stuff? Yeah. Cool. Good luck. It's a challenging exam. For me, it was, at least. I'm sure you guys will nail it. All the best with it. And, the sessions that come through in the coming months will obviously get slightly more targeted towards the viva. And make sure you keep up the written exam prep. Like, it's very easy to nail the viva but fail the written, and vice versa. And the written exam is, it's, at least it used to be, so 2.5 hours of just having to pump out a lot of content. So don't overlook one for the other. Otherwise, all the best, and see you guys next week.